As a consultant pediatrician, he has served in many parts of the island and has been instrumental in raising the overall standard of pediatric care in all these places. His involvement with dengue has turned a new chapter in the management of this deadly illness, not only in Sri Lanka but also in many other countries. He is well known locally and internationally for his work in dengue. He was instrumental in developing new strategies to combat dengue with the aim of providing the best possible care to those who acquire this deadly virus. He started the Center for Clinical Management of Dengue and Dengue Hemorrhagic Fever in Negombo, which treats both children and adults. He is also the current president of Sri Lanka College of Paediatricians, and under his able leadership, the SLCP has started many projects including regional scientific sessions. So, the right person is here to talk to you about how to handle the current dengue epidemic. So, may I now call upon Dr. Lakkumar to deliver his talk on dengue. Thank you.
Thank you for that kind introduction. Fine. Now, most of the things that I am going to tell you is not what is there in our guideline. Therefore, you should have enough disagreements. So, please do not silently tolerate your disagreements. Ask questions. Healthy confrontations are useful and welcome. Agree with me, that will help me to think better and find better solutions. At each time that I talk on dengue, I also learn from something from the audience. Right. What I am going to do is that to talk about my topic while sharing my first-hand experience of managing a relatively large number of dengue patients, both children and adults, non-stop almost every day, continuously for the past 84 months. I was pediatrician in Gampaha somewhere in 2009-10, and I had the opportunity to go to Thailand on a dengue training, because in 2009 we had the highest number of dengue deaths in Sri Lanka, 346 with 35,000 cases. And I was the Gampaha district had the highest case fatality of 2.3%. The national average was about 1%, and so they selected people from Gampaha district, and Kandy was the second highest on a case fatality rate to be sent to Thailand. But I was not the first to go to Thailand. There were at least 20 others who went to Thailand before me for the same training that I received in Thailand. After I returned from Thailand, I remember I returned on the 22nd of May, almost 7 years ago, 22nd of May 2010, and nobody asked us what we learned, and sort of life went past until on the 21st of June, 1 month later, I thought I should share or tell the other people what we learned. Then I asked the other 5 people who went with me and organized a workshop, full half-day workshop in Gampaha, in a hotel in Gampaha. Invited 50 consultants who are pediatricians and physicians, and told what we learned, and told that that time the prevailing guideline was not quite the best one for us to manage dengue. There are many changes that we need in the fluid therapy and so on, and wanted those 50 people to start managing dengue differently, so that at least the Ministry of Health will think of changing the guideline. In this whole, as a result, I was asked in July to come to the ministry to tell what we learned from Thailand, but I was given only 15 minutes. Myself and Anand Vijay was given another 15 minutes to tell about the laboratory. Yeah, he told, how can we tell the ministry people all what we learned in 2 weeks in 15 minutes? You take my 15 minutes also. I talked for half an hour, and that's how this whole process of my talking about dengue started. Since then, I've done about 150 workshops. Now, of course, I manage several dengue patients every day continuously. So I have had exposure to all forms of dengue. Now, during the past 7 years, I have spent hours and days at the bedside of thousands of dengue patients, morning and night, and always lived within 5 minutes of the dengue treatment center that I cared most my patients for. So whenever there was a problem, I was able to physically go there and see. So all what I am really trying to tell you is what I have seen and felt. Right. This is the. As soon as I returned from Thailand, I made this first dengue high dependence unit of Sri Lanka in Gampaha, and this was inside it. And then I had the opportunity to go to Pakistan when they had the biggest dengue epidemic. The next dengue high dependence units were built in Thailand, in Pakistan. This was the time that I had the exposure to managing a lot of, I went there 4 times, adult patients, morning and night. Then later on, when I switched from Gampaha to Negombo, I was able to start the Center for Clinical Management of Dengue, where we could manage both children and adults. That was also in response to something that I will not tell because of the time. So this is what it is now, and we have had in Gampa Hospital, in Negombo Hospital, we managed more than, from the time that we started this, more than 50,000 dengue patients. Just today we have between 300 to 400 dengue patients in the Negombo Hospital, of which 17 are inside the dengue unit. So the dengue unit have only the most severe 17 at any given time. The dengue unit alone has had 5,800 patients by today from the time it was started in 2008. Several times more patients were treated in the hospital during the same period. Now, I am going to talk something slightly different to the fluid regimes that we are now following. It's not actually the guide, we are not, this is not different to the guideline, but this is a kind of a more specific application of the guideline. It's applied to more than 50,000 dengue patients over the last 3 to 4 years, while maintaining the lowest case fatality rate for all dengue centers in the world. Right. This is Professor Suchitra. I show her in all my presentations because I learned nearly most of my dengue from her, and I have a great gratitude to her. Every time I was stuck with a problem that she was, then she encouraged me a lot. She's the person who was exposed to dengue in 1958 when she was young, and as a young new pediatrician, now she's 85 years and she's still very much active in the process. This is the first branch of our dengue unit in Negombo, which was set up in Kenya some time ago when Kenya had at a row about 22 dengue deaths, and by setting this up and by the help of the registrars and other people who went there, this was built within kind of 48 hours after my visit, and this is some of you may be here, and we were able to halt all the deaths. These are some of the dengue patients. This is hemophiliac dengue. This is a patient who had a cardiac transplant and came to Sri Lanka, got dengue. He was on immunosuppressants as well as anticoagulants when we were managing his dengue. I took these photos this morning from our dengue unit. I just wanted to tell you the first, we have 17 beds, the first 6 beds. I took quick photos and put it into this while I am on the way. The first patient is a patient who's got dengue. She's only just 4.5 days of dengue, but by day 4 her SGOT has gone up to 13,000 without developing any leaking. She's only a DF yet, she has no leaking, she's developed, she has got I'm just going to show you the range of people out of the first 17 cases that we are managing inside the dengue unit. We have hundreds of DHA patients in the medical and the pediatric wards. So she is somebody who had now her SGOT is come down to 6,000 from 13,000 yesterday. But it is due to the direct effect of viremia. She also has she's a diabetic in addition. Her serum creatinine is 6.3 in the morning. She might need dialysis. The second one is a pulmonary hypertension due to an ASD, who is in her second 24 hours of leaking. The third one, she is an interesting patient who came to us with bilateral pleural effusions of 8-9 centimeters. Her leaking ended in 3.5 days of fever. She was admitted after her leaking was over. She came with a lot of dyspnea while the fluid was, because she was managed in the medical ward, and she had already started leaking, and the leaking was over by 3.5 days. So that's something that we have not seen in the previous epidemics that we are seeing in the present epidemic. This baby was taken over by us yesterday. She's an 11-month baby who has a problem of her pulse pressure being low. Now it's being done. This is another lady who has DHF, and she's in a pregnancy. And that other one is also the DHF. He was admitted because his liver enzymes are in the range of 6,000. So that's what we generally on a regular basis see. Those are all who are in our dengue unit now, just now. I think in the management of dengue, the most important thing possibly is diagnosing dengue early. And I've been telling this for a long period. I do not know how many of you agree, but I just wanted to tell you, if you have fever for more than 2 days, 2 occasions within a day of more than 38 centigrade, that is also in the definition, 2 occasions within 3 days, or if you develop fever more than 38, even I would say during the dengue epidemic time, say 38 is 100.5, that it could be dengue. Now in the past, the island said that if you have such patients who has got leukopenia, and if you do a tourniquet test and test, there's chance of positive predictive value of it being dengue 83%. I don't think we need to do any of these things now. We have a very effective test, dengue NS1 antigen test. If you do the dengue NS1 antigen test on day 1 between 12 to 24 hours, your chance of picking up dengue is almost 99%. If you do it in a good kit properly, you can almost use this test to exclude dengue. It's as good as the dengue PCR. I have publication, an international publication done with somebody, where we said that it is as good as or marginally better than even dengue PCR on day 1. Now the other one is a dengue antibody test that could be done as IgG, IgM rapid test or an ELISA test. ELISA test is expensive and not possible to be done in any place. Now interpreting the antigen test, dengue antigen test I told. Now there is, if you read literature about dengue antigen test, it will tell that it is positive in the primary dengue, not so much in the secondary dengue. That's all in the theory book. It's not so. There's no difference between, we have looked at the way it is becoming positive in primary and secondary dengue on the first 2 days. There's hardly any difference. Now what if a patient comes on day 5 to you with suspected dengue? Will you do a dengue antigen test? Of course, in day 5 your chances of normally picking up dengue is only about 40% or less than 50%. But I would just still recommend that you do the dengue antigen test even on day 5. Because by day 5 if the test is positive, that means that there is persistent viremia. Therefore, this patient is likely to have more severe disease than a person with dengue whose test is negative on day 5. So it's worth doing it even on day 4, day 5 or any day. Positive persisting dengue. Now that lady who has got then when you do it, please make sure that you have to do it from a proper lab, proper kit. This is something that I picked up day before yesterday, done from a reputed lab. I don't know if it's correct to say reputed lab, but they were using a unregistered cheap test kit that gave a false positive, right? That gave a false positive. These are sort of is one of the three major or one of the two biggest laboratory chains in Sri Lanka, but they were using a unregistered kit which is smuggled to Sri Lanka to do the test. Now the antibody test, you will say that the antibody test, if the IgG is positive, it will say is past infection. If it is IgM is positive, it says recent infection. But if you look at the sensitivity of the antibody test kit, if you do it in any patient who has fever on day 1 where your indizone antigen is positive, you will not see the IgG. In other words, when you develop dengue, even if you had a past history of dengue, if you develop dengue and if you do the test, the IgG test on day 1, you will not see the IgG antibodies, because the IgG antibodies will be very low and a rapid test will not detect it. But if you do this test on the same patient, so on day 1 you do, antigen is positive, antibody both IgG and IgM will be negative. If you do the test on about day 4, you will see the IgG will become positive, because the IgG levels that was at a low level due to the simulation of the virus has gone up, therefore the IgG will become positive first and IgM will become negative. Don't send this patient away saying this is past infection and not new infection. By about 7 or 8 days after the patient is about to go home, you will see the IgM also becoming positive. So in short, if you do the antibody test, dengue antibody test in a patient, any positive is acute dengue. Any positive, IgG or IgM or anything, if you do the antibody test and it comes as positive, don't think it is past infection, it is suggestive of acute infection. I suppose that is new to you. Now when to do a full blood count? In the current epidemic, I was previously telling better to do the full blood count on day 3. I would suggest that you do it in the middle of day 2. We had many patients, including a foreigner who has never been exposed to dengue before, when she was from Switzerland. She had a full blood, the platelet count 90,000 on day 1 of fever. Now if you do the dengue antigen test and if the test becomes positive, then don't wait till day 2 or day 3 to do the full blood count, better do a test, because now that you know this patient having dengue, to get an idea where this patient is, better to do a dengue a full blood count on day 1 itself. If you do a full blood count on day 1 and if the day 1 full blood count is showing say 600,000-700,000 platelets, don't think this patient is quite okay, his platelet count is 700,000, no need to do it for another 3 days. There's nothing like that. Ideally you should do a full blood count on that patient on day 1, just one count. After the dengue antigen become positive, day 1 or 2 or whatever, and repeat it the next day and see how much it has dropped from the previous one. There was a patient who died of dengue whose platelet count was 485,000 on day 1. He got admitted on day 1. Day 2 it was 230,000. So day 3 morning, the doctor did not really have a look at the thing, because he said it was 230. But the doctor did not realize that it has come from 480 to 230 in 1 day. So the next morning actually it was 88,000. It was 88,000 with less than 8 hours from the 230. Right. What other test? When to do the liver enzymes? Probably about day 2-3 you should do a baseline liver enzymes also. That is how we picked up this lady whose liver enzymes were 6,000 on day 2 and 13,000 on day 4 without any leaking. You know that what dengue is. During the dengue epidemic, any fever could be dengue. So simply because the patient is having a ear discharge or having a pneumonic patch, don't think that the mosquito will avoid biting that patient. Once diagnosis is made, identifying DHF early from DF is the next most important step for best outcome. You know that 95% of all dengue deaths occur in the DHF group. Now, there's a lot of debate about classification and so on, but it is believed that these two are all people who are seriously involved with dengue, including myself, believe that these two are two different conditions. DHF is not badly managed DF. However badly managed you DF patient, that patient will not become, that's probably determined at the beginning itself. So that's the difference between DF and DHF. Now, how to diagnose DHF? We had traditional methods of diagnosing it. I think I was the one who introduced ultrasound scanning to detect leaking for the whole world, to detect dengue as in the routine use. Now we know that we can, this is a better way and more objective way of diagnosing leaking if you do serial ultrasound, whether when the fluid is accumulating. This is an example of a patient from a teaching hospital. I think a registrar has written this card. It says dengue hemorrhagic fever, but the lowest platelet count was only 95,000, and I don't think this was I emailed it to the consultant to say this is probably not DHF. It says bilateral iron reduced. Clinically, why should you be in a teaching hospital and diagnose DHF like that? The card says clinically leaking. Right. With ultrasound, you have to suspect DHF if there is pericholecystic fluid or little fluid in the deep pelvis, but you have to see it progressing. So, little fluid in the deep pelvis, sometimes even a thin rim of fluid in the pleura may not be progressive. That's the reason why you should do it again. If you have ascites, usually they are mild leakers, and you have pleural effusions, they are likely to be EB, but again in this episode we have seen something slightly different. Right. So, if you have a patient whose ultrasound is negative with a platelet count of say 100,000 or below, that patient is either a DF or a DHF who has not started leaking yet. This is our dengue unit, how patients gather in the hospital. This is an old photo and a new photo. How many, this was taken few days before, showing this is the scenario in the night, even today or any other day. These are all potential DHF patients or many patients who are leaking, who are in the Negombo hospital, who are coming to the dengue unit in the night to do ultrasound scanning. One of my MOs told me that he did about 3 weeks before, he told me he did 600 ultrasound scans during on one Sunday. Right. So, that's the kind of workload and the number of patients that we are seeing. That is why I am telling you that I am telling my experience of going through and seeing many dengue patients. This is one of, some of you may be knowing, Shama probably know who she is. She was she's one of our HOs who was a demonstrator in your unit, who is doing a bedside ultrasound scan. This is now. So, ultrasound is useful to detect the onset of leaking, but to confirm the progression, we also have to keep doing some capillary hematocrits as well as look at the other parameters. Remember, we have seen such a large number of DHF patients that I would think that the leaking of dengue never exceed 48 hours. In most patients, the leaking is only for 24 to 48 hours and not 48 hours. Now, if a patient does not leak for 48 hours, his fluid quota is not M+5. If he leaks for only 24 hours, his fluid quota is half of M+5. So, that is something that you need to remember. You don't. So, if you might say that you overloaded the patient, but you never exceeded the fluid quota. That is because the patient leaked only for 24 hours. You gave 75% of the fluid quota, and you say, how can this patient get overloaded? How can this patient develop signs of fluid overload? That is because the patient leaked only for 24 hours. You gave 36 hours of fluid. Still you are below the 48 hours fluid, but that patient can get fluid overloaded. it is good to think that everybody will leak only for 24 hours. One of the things that I have seen in the current epidemic is probably many patients are not leaking for the 48 hours. So everyone will leak, they may leak a lot, but might stop earlier. So everybody will leak for 24. You think that everybody is leaking for 24 hours, and after that, then look for the parameters to see whether the leaking is progressing, rather than saying make a leaking your head house and keep giving fluid when the patient is leaking, everything is over and fluid is now returning. Right. So the current dengue epidemic, some observations that we have made in our center. Majority of the patients do not leak for 48 hours, and many may stop at 36 hours or earlier. Their fluid quota is 3/4 of M+5 and not M+5. In few patients, leaking can start as early as mid of day 2. Few had entire leaking completed by 3.5 days. Few started leaking as late as day 7. If counts are dropping, even at day 7, you can discharge, but you have to just be watchful that this patient might leak even after day 7, occasionally, not. Then very occasional patient, say 1 in 10,000, we had about 5 of them, leaked with counts above 150,000. Clearly documented, very few cases, but it is rare. I don't think it's best that you always think that the patient leaks when the platelet count is below 150,000 and go on like that. You might never meet this occasional patient. Even if that you meet that patient is not going to give you a lot of trouble. I have one such patient now in the private sector. So no patients are observed to have leaking continue beyond 48 hours. Now remember, when you say beyond 48 hours, if you keep looking at the ultrasound evidence of leaking and measure the fluid levels, simply because that you will see the fluid levels going up beyond 48 hours, say at 48 hours in the morning, now 48 hours completed today, 5 centimeter, in the evening you said 6 centimeter, doesn't mean that it is continuing to leak. You will see all the other parameters are becoming good. It is like floods. If you see, I was in Ratnapura where there were a lot of floods during my childhood, and you remember once the rain everything is over also, you can get the water level sometimes rising, especially you will see it in Kalutara or down, that is the kind of the flooding effect of the fluid moving. So you can have a little bit of fluid rising towards the end of it, even after the leaking is over. Right. These are, I'm not going through this. I learned dengue from Thailand, and this was a talk that I gave in 2010 about what is new, and showed this chart. This is the I now doing. These are our guidelines that shows to give 5 ml of crystalloid, 7 ml. These are all things that we should not be doing now. Actually, our guideline needs some change. Then when it comes to adults, or actually bigger children versus small children, we cannot get 5 ml of a small child is not 250 ml in a big one, according to the Holter sugar formula, which was discovered as early as 1957. He clearly showed why, if you take a 50-60 kilogram person, if you want to give 5 ml kg per hour, the corresponding fluid rate is not 250 but 100 to 120 ml. So that's the reason why if you give 5 ml and 7 ml and so on to adults, that they give fluid overload very badly. Right. We some time back analyzed our fluid rates in our patients, and then decided what's the best fluid rate that we could manage most of our patients. And accordingly, we thought most patients, the basic fluid rate that you need to be managed throughout their illness is only 1.5 ml per kg per hour, not in a pyramid fashion. Now, in doing so, the most important parameter that we have to monitor is pulse pressure. Pulse pressure, you have to make sure that the pulse pressure is more than 30, not 20. There is no literature on dengue that says this other than the presentations of myself, because we are all waiting till the pulse pressure drop below 20. 20 is shock. So what we need to do is we need to maintain the pulse pressure above 30 all the time. We have measured it we have a big database of more than 5,000 dengue patients, which we have looked at 89 variables in SPSS chart, even the neonate, even the very small baby will have a pulse pressure of 30. To adult of 75 years to or 50 years to a young baby of 5 months, the systolic diastolic can vary, the pulse pressure will be 30. The 30 pulse pressure is the pulse pressure that is needed to pump blood across tissues. So that is what you need to maintain. Then you need to know what the heart rate is, and whenever the heart rate is high, if it is without fever, you need to find a cause wise. Then the other important parameter is urine note. Out of the 3 parameters, the most important is the pulse pressure. So we need to check these parameters while monitoring. If you get a good well patient, simply because the systolic blood pressure is low, don't think that this patient is having hypertension or bleeding and try to give blood. This is a good example of a 25-year-old man, very healthy person. His blood pressure is 86/42. This is we have documented this in thousands of patients. This doesn't mean hypertension, and this patient does not need blood. If you same story here. Now this is an example which I have shown previously of a child who is coming to hospital and receiving a lot of fluid, and as much as 100% of the fluid quota in 18 hours, and 200 more than 200% by about 38-39 hours. And obviously if you give fluid like this to a patient, the patient has to die. But to make things better, dextran and blood and everything was given, but it didn't really do. The piece of paper that you are given here is actually something that we developed, we are practicing as an answer to this problem of how to handle reduction in urine. Okay. Whenever you have reduction in urine output, your knee-jerk reaction is to increase the fluid and keep going. I am just telling you not to do that. And this is a kind of an algorithm that shows what you can do for that. I'll take it through you. So what we do is, if a patient comes with dengue, if you are managing a dengue patient, I mean I've managed a lot of dengue patients in the private sector as in addition to managing patients in the hospital. All these DHF patients I could manage and walk around, mainly because I stick to this fluid regime, which is very simple, easy, and it's not very labor intensive. Up to the time that your platelet count is about 150,000, of course you have fever, co-infection, you have to treat them. If you have vomiting, you have to replace the fluid. But you can ask them to drink and eat whatever amount that they want and maintain their normal urine output. Make sure that they pass urine as normal. And from the time that the platelet count come down below 150,000, then you will have to think of restricting fluid. When you say 150,000, because by the time the patient come to you, it may be 100,000, or he may have started leaking. 150,000 maybe in the morning. So 140/30, you will have to start some fluid restriction. The total fluid quota that you really need is 4,600 according to what is being mentioned. But I believe that most patients can be managed with only 80% of this. And once DHF is diagnosed, keep checking the amount of fluid given on a time scale. You need to see this patient would have started leaking. Suppose the patient is 50 kilos, he can be given 4,600 ml of fluid. We first noticed his fluid in the morning at 9 o'clock, and we thought that he probably started from 3 a.m. in the morning. Now it is 3 a.m. today, so it's 24 hours of leaking has happened. We have given him 3,000 ml of fluid, means ideally if you are giving on a time scale 4,600 for 24 hours, we should have been giving only 2,300 the maximum. But if you are given 3,000, that means that we are given more, we are not exceeded the fluid quota, but we are on a time scale, we are heading towards fluid overload if you give fluids like that. So while giving this, you try to see whether you can maintain the parameters with the minimum amount of fluid, but not with adequate amount of fluid. I mean, one of the teachings about this is to give adequate fluid. I am telling, give just adequate fluid rather than adequate fluid, minimum amount that needed to maintain parameters. If you, as a result, if you are remaining, if you are, suppose that all the parameters are good, but you haven't given a lot of fluid, fluid quota is remaining, keep it, doesn't matter. Sometimes this may be useful, you can use it later. This is the principle of of this fluid therapy and controlling leaking in a healthy child of 10 kilograms. The normal fluid intake is 3 ml. You would expect a 2 ml of urine output and insensible loss of 1 ml. If that child develop dengue, he leak 1 ml of fluid. As a result, the urine output will come down to 1 ml. Now, if you give that to 5 ml to increase the urine output back to the 2 ml, instead of the natural leaking of 1 ml, he is going to leak 2 ml. His leaking will increase as a result of your attempt to increase your urine output. But instead, you can give less than your normal maintenance. You can give only 2 ml rather than 3 ml to this child whose urine output dropped. Then his urine output will further drop to 0.5, which is enough still for 48 hours. Insensible loss will remain the same, but his leaking, which was originally 1 ml, is now 0.5 ml. So, that is the principle behind giving less fluid to control leaking. Now, one of the key things that I want to tell you is, this is why that you have to give less fluid and maintain the parameters of pulse pressure above 30 millimeters. Now, controlled versus adequate fluid, M+5 is recommended by Thailand. With my bedside experience, I strongly disagree with those who think you can even give M+7%, M+10% or M+15%. You cannot do unless you are an expert on ventilation and you have readily ventilators with you. Because one thing one observation that I want you to reckon, that is, we've had during the past 5, 6, 7 years about 40,000 dengue cases every year, 30 to 40,000 dengue cases every year. For 7 years, it's about more than 200,000 dengue patients we have come across in this country. But we have never heard of a patient dying of dengue leaking at home. There are many patients who cannot come to hospital, they are sick, they don't have anybody to take them to hospital. In an epidemic like this, we should really hear few people suddenly admitted dead, or you start leaking at home in the night, you are not drinking, there is nobody at home, therefore few patients should die at home due to leaking. But really happens is when you are not taking fluid, the leaking slows down. All these patients die after coming to hospital. So, we haven't seen deaths at home because of the natural control of leaking when you are taking less fluid. Please take that as an important strong message on our observation, because if patients can just leak because they don't take adequate fluids, if patients die, then we should see few dead on admission or patients not being cared for dying due to dengue during this kind of an epidemic. So, give just adequate fluid. Giving adequate is good for the present, but not for the future. So, you have a patient, you are on call today, you can give a lot of fluid and nicely manage your on call and go tomorrow. The person who is taking over the next day will have to face the music. You can be in trouble if you don't have a ventilator, if you give such fluid. More fluid, more leaking. And even when you give more fluid, you will need more leaking, therefore you will need even more fluid. That's a vicious cycle. Control fluid better than adequate fluid. So, this is the fluid regime. Then normally to any patient whose platelet count is less than 150,000, you just give 0.5 ml IV and 1 ml oral. If you actually speaking, we manage thousands of patients who's come to us with a platelet count of, I manage many of them who's come to me in the private sector, whose platelet count has dropped to 6,000, 7,000, they develop bilateral pleural effusion and so on. When they were started on a fluid regime of 0.5 IV, 1 oral, as early as when their platelet count is 150,000, none had any problem. They all went through the leaking without any problem. But when they were, now when you are giving like this, for a child 10 kilos, you give 5 ml IV, 10 ml oral, while monitoring the urine output every 4 hours. You will catheterize the child sometimes if your platelet count come below about 50,000, up to that you probably monitoring it every 4 hours is enough. So, for an adult you will tell 50 kilogram person you have to have something like 0.75 ml of urine, about 150 ml of urine every 4 hours. If the urine output drops to below 0.5, you have to intervene. You need to look at what the target heart rates that you would look at. If the heart rate is high, again you will have to think of intervening. Maintain the urine output like this. If you can, when these patients' counts are coming down below about 100,000, if you can ideally monitor it with a multipara monitor. Now of course, even in our setup, the number of multipara monitors are increasing, but they are never enough in a place like Negombo where we have a lot of patients. Now if you have a pulse pressure between 30 to 25, that patient can become a problem. Occasionally, very occasionally, there are a few patients, I would say less than, I said that everybody's pulse pressure is about 30. There can be less than 5% of patients whose normal pulse pressure is about 27, 28. There are very few of them. So if you have your pulse pressure between 25 to 30, then you need to be worried about it and you have to think what you are going to do about it. And if it remains more than 20, say between 25 to 30, you have to inform and plan intervention. By any chance, if it goes below 25 and remains over more than 30 minutes, you have to intervene without delay so that you prevent shock. If you do this, you will have no shock patients in hospital. If a patient comes in shock, once you resuscitated, there cannot be 3, 4, 5, 6 shocks. All these people who tell our patient has 6 shocks and all instances where you could not prevent it. I think the number of those patients who have 6 shocks, 5 shocks at a place like Leregia is now very much less. Right. Again, how much fluid? In most of the DHA patients, we looked at the amount of fluid we gave to them during their leaking. They can be managed with about 80 to 90% of the fluid quota. They really more than 70, most of the patients, they won't need more than 80 to 90% of the fluid quota. If a patient is admitted halfway during leaking, if the patient is tachycardic and low pulse volume, you have to resuscitate first. How do you resuscitate? Our guideline says when pulse is not palpable, you have to give 20 ml per kg of normal saline as fast as possible until pulse is palpable. Then 10 ml the next hour. So once you do this, most of the time your pulse pressure might come to 30. If you really look at our body has 70 ml per kg of fluid. If a patient is alive by the time it comes to you, he at least has about 30 ml per kg of fluid inside the body, vascular compartment out of the 70. 30 to 40 ml is remaining, that is why he is alive. He has only 20 ml, he will be dead. So all the live patients who come to us, they already have 30 to 40 ml. We give another 30, it comes to almost 70, though the leaking can continue. Normally the leaking is not faster than 10 ml. So whenever you are giving 10 ml per kg, you will be on top of the leaking. So every time that you give such fluid, your pulse pressure should become better and not get worse unless you have associated bleeding or so. When you do this kind of fluid, you will see most patients, they will have their pulse pressure coming about 30 millimeters and heart rate will come down to about 100 if there is no fever, and the urine output will come to 0.75. Once you have this, switch to 1.5 ml. Now just because what you all normally do is, now this patient is given a 10 ml and 20 ml and 10 ml, and after that you are going to give a 7 ml for the next 3 hours, 5 ml for the next thing, because you think that this patient has come on that's the teaching that I myself did years ago. They have come of first 24 hours of leaking, now in the descending limb that you need to give all that is not right. That is my observation. It's up to you to believe it or not, but I am telling you that we have excellent results doing it this way. So don't give 5 ml. Now once you are on top of the patient's pulse pressure, you have got a 30 ml. Now everything is fine. Now you are coming right down to 1.5 ml and do PCBs hourly for the next 3 hours to see what happens. Whether the patient is leaking a lot and whether your 1.5 is going to bake the patient back into shock. Suppose the patient's pulse pressure has come after your 20 ml and the 10 ml, the patient's pulse pressure has come down to 35, and the PCB that was 55 has now come down to about 47 or 46. You do keep hourly PCB while giving 1.5. You will see the PCB bit was 47, becomes 48 the next hour, but remains again the 48 the next hour also. Then you know that it will plateau, and because you are giving less fluid, now the leaking is getting controlled. In such patients, I give 0.5 IV, 1 oral, and in the night, because the patient is sleeping, you give 1.2 ml per kg total at night. Anybody who is less than about 8 to 10 kilos, you can make this 1.5 ml, 2 ml. That's for the very small kids, because their normal maintenance is much higher. Right. Now 75% of those patients will not need more rapid fluid than 1.5 ml throughout the entire leaking phase. We have thousands of charts of patients whom we have given fluids like that. We never used at our center, we never used 7 ml per kg per hour or above for over 1 hour continuously, even in a single patient out of our close to 6,000 patients. No 5 ml kg for 2 hours or above to any of our patients. Actually, this includes another 30,000 patients who were managed in the wards. There were no 4 ml per kg for more than 2 hours, even in a single patient for the last 3 years. Less than 20 patients out of maybe 20,000 DHF patients, less than 20 patients, about 10 kilogram in weight, needed more than 3 ml for more than 3 hours. So in other words, what I am trying to tell you is most of you are probably giving a lot more fluid than what we give. You cannot believe or don't like to go down to that. Less fluid, slow leaking, more fluid, faster leaking. Now, I told this to many of my colleagues, friends, some of our former registrars who are now consultants in faraway places, give 1.5 ml. They have been trained to give 5 ml, 7 ml, 3 ml. They say, oh, okay sir, but they go and give only 2 to 3 ml. They say, but your fluid regime is not working, so they are leaking a lot and we need to give a lot of fluid. I asked why? No, we gave 2 ml, 3 ml. I said, who asked you to give 2 ml, 3 ml? I asked you to give 1.5 ml. So they think 1.5 ml is too low. We can't do that, but we'll do what as sir says and give about 2 to 3 ml. Actually speaking, 2 to 3 ml is worse than giving 4 to 5 ml. Because 2 to 3 ml, you will increase the leaking, but you don't give enough fluid to compensate for the leaking. So if you want to give either 4 to 5 ml or 1.5 ml. Don't give 2 to 3 ml. 2 to 3 ml is worse than 1.5 ml. That is the message that I want to give. Listening to my talk here, you reduce your fluid that you are giving for 4 ml and 5 ml, and tomorrow you start giving 2 ml, 3 ml, you will get into serious trouble. Right. Then now you will have to get into 1.5 ml and not 2 or 3 ml. That's something that I want to stress. If you have low urine output, I think the low urine output is the commonest cause of death or things leading to fluid overload and death, if you really look at the death reviews. And this patient is a similar case, because this one has 0.21, 0.3 kind of urine output, and as a result only she received a lot of fluid. This is a similar patient whom one of my colleagues, again in a teaching hospital, called me and told me, look, we have, I think he won't mind telling me, he said, he's Anujavardhana, he told me, he's in a new place, the registrars who has come from other places, they have already given the fluid quota in 24 hours, now what to do? He asked me, I told him how to take the other 24 hours without continuing that and make it 200%. So we were able to give just 1.5 bolus of dextran and manage the entire back 24 hours with only 1 ml. So it's always possible. Right, this is what I am trying to take you through. This is a way to, you try and practice this and see in your patients, but without your modifications of increasing a little bit, because this is evidence based. We have tried this, we have done this. So you give, when you have your platelet count above 150, below 150,000 and a pulse pressure of 30, the other side is what you will do to an adult. While on this, any loss, if you have vomiting, any loss that has to be replaced. while on this fluid of 1.5, some people will feel thirsty, some will not. If he is thirsty, you can ask them to take instead of the 1 ml per kg oral, they can take 2 ml per kg for about within a day about 2 to 3 times, not several times. And if the urine output drops within the first 24 hours to less than 0.5, check fluid intake on a time scale. Just try to find out how much fluid is this patient given. I was told about a patient like this morning. This patient's urine output has dropped while on 1.5, but the previously when you look at the history and how much the fluid patient has taken for 13 hours, he should be taking 25% of the fluid quota, but he's taken only 12% of the fluid quota. That means taken a lot less fluid. So that means that patient needs to come up to that level at least. So if when you calculate the fluid, suppose on a time scale, suppose this patient's total fluid quota is 4,000, and but you have to, for 24 hours he should have received 2,000. If he has received 1,600, that is 80% of the fluid quota, that means he's received adequate fluid. He's received adequate fluid. You don't have to necessarily give, he's received adequate fluid. If all the other parameters are good, but only the urine output is low, then what you need to do is to do what I said, increase the oral fluid to 2 ml per kg. If it is an adult patient who is receiving 50 oral or a more than 50 kilogram child taking 50 oral 25 IV, ask him to take 100 oral for the next 2 to 3 hours. If that does not improve the urine output, don't keep increasing. You change, you reverse. You are giving 0.5 IV 1 oral, you give 1 IV 0.5 oral. I have done this for hundreds of patients and we have documented that in many of them the urine output returns with this maneuver. Now after you do this also, still the urine output is not good. Even though the patient is in an ascending limb, is leaked only for 12 hours or 18 hours, you are justified to try a test dose of furosemide. You can give a small dose of furosemide, 0.05 to 0.1 per kg. If it is an adult of 50 kilos, you can give 5 milligrams of furosemide. Sometimes even if you think you have almost given 80-90% of fluid, you can give just 2 milligrams of furosemide. For a child, you can give a very small dose of 1 to 2 milligrams of furosemide, and most of the time the child will pass urine without you having to go to 3 ml, 4 ml, 5 ml and then overload the patient and take the patient in a totally different pathway. That is what this paper says. Now if that after giving that you give the furosemide, there is still no response. When you given the furosemide still no response means, what does it mean? That means the patient's vascular compartment is not full of fluid. The vascular compartment is not full of fluid, that is why he is not responding to the furosemide. Such patients, you calculate and see how much fluid you have given. If you have given 80 to 90% of the fluid quota, you have still more fluid to give. You just give another half bolus of normal saline. What you call half bolus of normal saline is 5 ml per kg of normal saline over 30 minutes. That will most of the time make the urine output corrected. If possible, get a capillary PCV before and after and see what happens. Suppose when you do a capillary PCV, in this patient if the capillary PCV is 45 and at the end of the half bolus it is still 45, what does it mean? Nearly all the fluid that you have given has disappeared or the patient is leaking a lot. But if the PCV was 45 before your half bolus and it is now after 30 minutes it is 42, that means after half an hour some of the fluid is still retaining inside the vascular compartment. This means this patient is leaking but not so fast. So you don't have to really panic and keep giving a lot of fluid to this patient. You give, if you are given, if there is still no response, by this time if you are given more than 95% of the fluid quota, then that is the patient whom you have to give dextran. Now when you are giving dextran, you make sure that you have given adequate crystalloids before giving this patient to dextran. Most patients will respond well to dextran at the beginning, but they will get into problems of urine output, renal clogging and so on if you give dextran without giving adequate crystalloids. So if you are given more than 95% of the fluid, you give dextran half bolus, and that will correct the urine problem. You can keep this paper which I printed for you to practice and follow. Suppose if you are given more than 110% of the fluid quota, that means you are still heading towards, you have already given 110%. When you give the dextran half bolus, it will become 125%. So you need to give fluid, but take that fluid also. That patient you give, even though you are in the ascending limb, you give at the middle of it, give 0.1 milligrams of small dose of furosemide at the middle. I would think 98% of patients who have low urine output will be sorted out through this, which we are practicing, we have applied. This is kind of Adduti Pratyaksha kind of thing. If still your urine output does not improve, you should give me a call. I will then tell what to do. Right, I think we are closing to 1 hour. I have a lot more to tell. We probably have another meeting to take you through. If I have something, I will just touch on few important things. Now, when you give fluid, how to know whether the leaking is over? One is that your clinical parameters will improve, but remember, your PCV may be still high. Towards the end of leaking, your PCV will be still high. Now, don't think because the PCV is 55, 60 that this patient, all the other parameters are good, that this patient is leaking a lot, and try to give this one another dextran bolus to bring it down, because soon this patient's fluid may be coming back. When the other parameters improve, then what you probably have to do is, if you have a patient who is fluid overloaded, we are given, suppose the leaking has ended at 24 hours, you are given the 36 hours of fluid, that patient will be having tachycardia and narrow pulse pressure. The treatment for it is not giving more fluid. When you give more fluid, it will momentarily improve during the fluid bolus, but soon after the fluid bolus, the patient will become worse again. So all what you need to do is to give that patient to take fluid out. One of the things you can do is, in such patient, you can again give the test dose of small dose of furosemide. Even though when the pulse pressure is low, you can give a small dose of 0.05 to 1.1 milligrams of furosemide. That will not make the patient go into shock. But if there is a lot of fluid in the vascular compartment, it will produce a large amount of urine, and the patient will become better. This is a chart that shows what really happens during DHA, but I just wanted to show you one thing, that in 99.9% of the patients, the platelets start rising after the leaking is over. So if you in this patient whom you think is continuously leaking, PCV is high, tama leak කරනවා මෙයාගේ scan එක උදේට වඩා වැඩි and all that, if you see the platelets have started rising, that patient has stopped leaking. You have to think that these patients, if you have a definite, if we have 2 consecutive platelet counts rising, once the laboratory tests are excluded, you have to say that the leaking has stopped, irrespective of the time of the onset of leaking. The leaking may have lasted only 6 hours to 2 hours, or maybe 12 hours, 24 hours and so on. Whatever the hemodynamic status, you have to keep in mind that this patient's platelets are rising, therefore this patient's leaking is over. Now don't give this patient fluid as for a leaking patient. Do whatever you want to do, but don't give as for a leaking patient. So low pulse pressure, this is what I previously also said. Now managing high PCV, usually associated with low pulse pressure, you should never give dextran before giving 15 to 20 ml of crystalloid. When a patient comes in shock, if you give a dextran, the patient will nicely improve. It doesn't mean that you are doing the right thing. You create problems for the future. Into a shocked patient, if you give dextran, the dextran can cause problems. Sometimes high PCV otherwise stable. Now, when you have a high PCV and you need to do in a patient, the first thing that you need to give a normal saline, either a bolus or a half. Suppose if you think the patient has got adequate fluid, you can give a half bolus or normal saline, that is 5 ml per kg of normal saline over half an hour, and see what happens. If the patient has a big drop in the PCV, that means all the fluid is retaining, but pulse pressure also improved and the heart rate was reduced, that means this patient is at the end of leaking. These patients, though these patients pulse pressure is PCV is high, this patient's leaking is low and almost the fluid is coming back. So your fluid and the returning fluid together increases the pulse pressure. That is why the patient improve and the big drop in the PCV. Don't think that this patient is bleeding. Then if you give there is a big drop in the PCV, but there is, when you give fluid, the big drop in the PCV, but there is no improvement in the other parameters, tachycardia remains also, that patient is bleeding. If you have a mild drop, that means a lot of fluid that you are given has leaked, very little is remaining. If there is no drop, when you give half bolus, the PCV was 45 before, after the half bolus also 45. That means all the fluid that you gave has leaked. So the patient is leaking a lot. Then you can decide when to give dextran. About use of dextran, few things. We have two brands of dextran which we are fighting. Why two brands are different? If you take dextran 40 is a mixture of several molecules. Some molecules are as small as 20,000, some are 60,000, some are 100,000, 80,000 and so on. It is the average molecular weight that is 40,000. So the Thailand dextran is a better recipe. Its average molecular weight is also 40,000. The Indian dextran is also average is 40,000, but the Indian dextran possibly has more larger molecules. As a result, it causes more renal clogging and also bigger drop in the PCV. When you have a bigger drop in the PCV, you think that the patient is bleeding and give blood loss, right? And that dextran is likely to cause more renal problems later on. Then about half bolus versus full bolus. You can actually use either a half bolus or full bolus. In our case, 85% of the dextran that we use are half boluses. If we give a full bolus, why we give dextran is dextran will keep fluid and maintain the pulse pressure for some time. If a full bolus of dextran is capable of maintaining pulse pressure for 5 hours, two half boluses can maintain it for about 6.5 hours. It means that two half boluses are more advantageous than giving one full bolus when you think of spending time on during the leaking period. Then if you give dextran to a patient whose PCV drop a lot, we have been told that it is due to bleeding, not all the time. Remember, if the patient's clinical parameters does not get worse, if you give a dextran and if the PCV drop a lot, that is a patient who is recovering or whose leaking is over or whose fluid is coming back. Now, dextran's volume expansion plus the returning fluid together will make the PCV high, whether the drop high. Now, immediately when this happens, your reaction is to give this patient blood. When you give this patient blood, the PCV will go up again. Then you give more dextran. Then this patient, at a time of the fluid returning, you are giving fluid. So this patient who was just about to recover. This is the case I looked at many dengue death PhDs. This is the case of many patients whose you give. So blood transfusion is something that you need to think and do. Remember, dengue hemorrhagic fever name, Professor Suchitra said she is the one who named it as dengue hemorrhagic fever because she wanted people not to forget to give blood. So you can have massive bleeding even in DF. Blood is an important thing. But if you have a patient who has persistent tachycardia, most of the time, nearly 90% of the patients who had significant bleeding, that if you have more than 10% blood loss, you need to transfuse that patient. If you have more than 10% of your blood volume bleeding, nearly all the time, that your white cell count will go up. You will have, after half a day, you will see there is neutrophil leukocytosis. So if you have a patient whom you think is bleeding and you are giving blood, but the white cell count remain 3.5, 5.5, even after 2-3 days, just question your decision, because when you send this patient home, you will see that the baseline HB is much more 1 or 2 weeks after when you do this. That is because of unnecessary blood transfusion. You can also do the stool focal blood. I think I'll stop here because of time. If you have any questions, you can ask. There are a lot more to do. We'll do it some other time.
You said if the platelet count drops below 150,000, one has to restrict fluids. So does it mean that you have to admit the patient?
Not necessarily.
So how do you restrict fluids at home?
Not necessarily. You need to give a kind of an oral target, how much fluid to take. Now admission, actually, especially these days, admission you will have to, if you are not feeling well, then you have to admit the patient. Sometimes home may be even better than hospital. I think myself and Professor Lamavadu Surya was in Singapore. At a time, one dengue patient died in Negombo. This was a 39-year-old man with 3 children who's come to hospital with a platelet count of 127,000. On that day, there were 145 dengue patients in the male ward alone. They have only about 65 beds. So there were many patients who were in 2 beds. There were many patients who were worse than him. But because he is 39 years, fit patient, otherwise well, he was asked to drink 80 to 100 ml of, they were actually told to drink 100 ml of fluid every hour. In the ward, they asked him to drink 100 ml of fluid. Now he did not have a bystand. If I want to ask me, what is the most important thing in the diagnosis, in surviving with dengue? I think the most important thing is knowing whether you have dengue the first time. Second thing is whether you have a bystander throughout your illness, at home or wherever. If you have a good bystander, your survival is, all the patients who have died because they did not have a good bystander. Because there is warning signs, there is enough time where things are not getting better, but the patient himself is unable to go and tell this. Or you have a very weak old seer as a bystander, he can't go and tell anything. So that's the reason. This man stayed in the, he had 3 children, so he asked the wife, you be at home, look after the children, I can be here. But when fluid started leaking, he cannot control himself, so he kept probably drinking up to a time that he probably became weak and he stopped drinking. The next morning the wife came to see. The wife felt that he was very, very cold, and therefore he anyway he said he wanted to go to the toilet and come. He came from the toilet and collapsed and arrested, and that's how he died. Actually, if he had a good bystander, if somebody was giving him, or if he was at home drinking fluid, or his wife was giving him fluid, he would have survived. When at that time it was 20,000. So the interval was about 6 hours, 6 to 7 hours. Actually speaking, when your platelet, all this, when your leaking becomes aggressive and progressive, your platelet counts will also come down drastically. You will clinically become unwell. So you can actually take home if there is somebody to look after you. But if you are staying alone, you better get admitted in hospital, at least somebody, yes.
If the count is between 150,000 and 100,000, how often should you be repeating the platelet count?
If you are feeling, ideally that kind of patient needs TDS platelet counts, 3 times a day platelet counts, unless you are feeling very well. Yeah, you are feeling very well. It's like this, we have to overdo many things if you want to have zero mortality or avoid all the deaths. Certain things we can do, you said we can't, you better go home and come. If you send patients like that, maybe 1 or 2 will die, many will survive. But if you want to save every life, then you probably have to do a little more. That is why we are trying to make more dengue medicine, more beds, more monitoring, more to reduce deaths.
About patient feeling well and patient feeling sick. An adult can express, an older child can, but not little children.
If it is a younger child who cannot say anything, it is safe to admit such.
Safe to admit.
walk to the toilet, you say.
Now, when you say walk to the toilet, you can actually just before death, if you really look at it dengue, when your pulse pressure is 20, you can be talking. Maybe that all these
So
compensated.
how come he just died? You said he just had an
No, he was in the ward. He fainted and kind of.
But I
for
feel
instance,
if
there
you
would
have
been-
done a post-mortem, then it would have shown why
No,
he died.
post-mortem was done. Don't worry,
What
post-mortem
did
was
it
done.
show?
All that was looked at. Because one thing we need to realize is, there are many patients who can get into shock and die like that. Because when your hemodynamic stability is lost, suppose your pulse pressure into your vital centers in the brain and everything is only 15 millimeters, even your respiratory center will not work. If your respiratory center will not work, so his compensatory mechanisms work. If you take for instance 10 patients who will collapse like that, maybe 8 or 9 will survive.
What did the post-mortem show? What did it show?
Post-mortem showed bilateral pleural effusions, evidence of shock. Those are what the post-mortem showed.
No hemorrhage, no cerebral
No hemorrhage, no cerebral hemorrhage.
Now what we find is now most patients are dehydrated when they get admitted. So if they have a fluid deficit. So if you are to stick to this low volume, most of the time you are okay. But sometimes you might encounter problem with a very low urine output.
You actually need to, now I will give you an example. If you give, when a patient comes to you with a high PCV, if you give the fluid and then repeat the PCV, and the repeat PCV shows that suppose a patient can come with a PCV of 55, even without any leaking, or maybe with very mild leaking. His height rate is 120, 130. You give just 10 ml of normal saline, the PCV will just come to 48 by 7, just for normal saline 7 ml, and the heart rate will come down. That patient's high PCV is 80% due to the dehydration, 20-30% due to the so actually the initial resuscitation, that is why you need to first resuscitate. If there is vomiting, you have to give that, you have to correct the dehydration, do all that, do a PCV and get an idea, is this PCV high because of dehydration or because of leaking. If it is due to leaking, you will see that the PCV is 55, even after normal saline, it is still 55. You will see it many times. This patient has been taking fluid, you give, it doesn't, because most of the fluid that you gave is not retaining inside, because it is leaking. So all this once all the dehydration and everything is corrected, then you will get into a pulse pressure of 30 and a heart rate of 2. Then that is why that we keep giving the next 3 hours. I want you to do hourly PC for the next 3 hours while giving 1.5. That will tell you whether your 1.5 is enough or not. Most of the time what happens is, when you give 1.5, the PCV that comes to 45 will become 47 the next hour. The next hour you will see it go by only 148. The next one you will see it is still 48. Sometimes if you do it the fourth hour, you will see it is back to 46. So that means that it will plateau, it will take time. But if you keep giving 5 ml of fluid, you will see that the PCV is gradually going up because the leaking is progressive.
All the fluid that you are giving is leaking out.
Pardon?
The child with normal kidneys, now 1/6 of the cardiac output goes to the kidney. So why are you assuming that the fluid that we are giving, say a little bit extra, right, that it is really leaking, and now why can't the child's kidney function properly and flush it out?
Now, if the patients, there are some patients who you will see there's hardly any, sometimes you will see you are giving 3 ml per kg, it is passing 5 ml per kg of urine. And sometimes you are giving 3 ml, is passing 3 ml. So in other words, you have some.
I am saying, Lakuma, is, but now we have been attending these dengue mortality meetings.
Yeah.
Most of the meetings, what I have seen is people who try to stick to this 0.5 ml per kg per hour. These are the patients who have ended up with sort of, this bleeding and DIC. What in my ward, what I
No,
do is
I'm-
I give a little bit extra fluid. Actually, I stick to around 1 cc. And as you are doing, I also give furosemide. Usually, descendingly, I start giving furosemide. And I've never had any problem.
No, I only explain the way I handle patients and I showed my results. Of course, I think my last slide shows that is telling that dengue can be managed in many different ways. If you really look at it, you can actually this is a condition which can be managed in many different ways. It is not, there is no one method that you can, but all what you need to do is you need to try and see how smoothly and how comfortably that you can take. I mean, I am a person who is around my patient most of the time, and I am available for my patients whenever there is a problem. I can come, and this is what I am comfortable with, and as a result I am managing our dengue unit, many other patients over the phone, and more than 20 patients at any given time in the private sector. They are all doing successfully. If you think you are happy with your fluid regime and you are quite good and showing good results, all what you need to do is to stick to that. But only thing what you need to realize is that dengue changes the way we manage the patient also. And most of the patients are anyway, whatever fluid that you give, they become better. If you really look at it, even the Ambalangada Vedahamini has claimed so many cures, but we need to stick to some system so that we don't even have the occasional death or the occasional patient who will get into trouble, and also the patient will go through this without much problem. In my case, I was being in a learning curve. What I did 3-4 years ago and what I do now is not the same. I have observed very closely the response to my fluid, response to and come to this stage. So I'm sure I can even change beyond this, depending on the understanding I will have.
Day and was sent home, but next day when he was brought to the accident service, there was no heart sound and they had managed to resuscitate. This was also discussed at the dengue mortality meeting.
So that means
Just
the diagnosis of dengue was there before sending.
I think the OPD doctor had not done a platelet count on day 2 and the child had been sent home. Just to highlight the fact that the patient can die even at home. So if there was a delay, maybe another hour, the doctors would not have been able to resuscitate. But ultimately the patient succumbed. But this is just for the record that they can, especially the infants.
It is rare, it can happen, but whether the patient died due to fluid leaking and or whether this is the patient, because if you really look at it, during a dengue epidemic, you can die of a heart attack and your NS1 can be positive if you also had the dengue virus in your body at that time. So you cannot always attribute all the deaths where the dengue is positive to dengue. I remember I went through some 500 dengue death BHTs in Pakistan when I went. They were trying to find fault with many different people, because at the time where the entire Pakistan was down with dengue, so many people had, I mean, you can have a road traffic accident and die, and then your dengue antigen can become positive. That doesn't really mean that it is the cause of death is dengue. If a patient dies at home with dengue, that is that the patient should have leaked and as a result gone into shock without anybody noticing. But at least we should realize that the way that we have this leaking disease, we don't at least see many, we should see many dengue deaths if patients naturally leak due to lack of fluid.
What we must request is that we should be doing postmortems in all these cases.
It is a necessity by the Ministry of Health. I don't know whether it's not done here or not. All the dengue deaths that should happen should have a postmortem. There is no way in which you could not do a postmortem. The only thing is that you need some interpretation to the post-mortem findings, because you can have somebody who's being resuscitated and given a lot of cardiac massage, and you get mild tiny hemorrhages from the heart, and the JMO can say that this is due to myocarditis. That kind of thing can happen. But it is because of the postmortem surgery. I mean, Professor Suchitra tell me that she does not believe that there is myocarditis in dengue, because there are many postmortems done for dengue deaths throughout the world. Just in literature, there isn't a single inflammatory myocarditis shown in the myocardium of a single dengue patient. So that is the reason why is that there may be a cardiomyopathy or a transient phenomenon like the vasculopathy we have, but no inflammatory reaction or no myocarditis. So the postmortem are one that have given that conclusion.
In a incubation who dies of shock, what is the post-mortem evidence of shock?
It's it is actually, sir, normally when a patient gets goes into shock, there may be other associated things. It's very difficult. Most of the time there is nothing that the postmortem JMO can say that this patient has died of shock, unless the body had appeared very dehydrated or anything like that. I mean, if you take for instance, you can have fluid overload and shock. In fact, majority of the patients who die of shock have fluid overload and shock. So the postmortem will show a lot of fluid, lot of evidence of fluid overload. The patient may be edematous, but still what is there inside the vascular compartment may be low.
But it is difficult to find objective signs of shock at a postmortem.
Yes.
I think most of these patients ultimately they develop DIC. So they develop DIC, and most of all the cases that were discussed, some had cerebral hemorrhage, and most of them ended up with DIC. So there will be evidence of DIC.
The cause of DIC is the treatment. You can create DIC in a patient when you send the patient into shock. When you give blood products, then when you cause blood, the blood will the products will be consumed. But if you really, even if you look at literature, that you will find DIC is a complication of management than the disease dengue. DIC is the one that when you have in prolonged shock, you have multi-organ failure for a few days, obviously due to any cause, you will find having DIC.
So they die ultimately of DIC and its complications. These people who have been in prolonged shock.
They have
The
been
postmortem
made
will
to
show
develop DIC due to the management.
I think we should request the ministry to make it compulsory, like for AB's cases.
No,
So the
ministry has
outpatient-
made a circular.
No,
there is a circular to my knowledge. But
even
there
that
is
day
a
when we
circular.
had the meeting, I don't know whether you were there, I in fact asked, and then Hasita was there, he categorically said no, because the whole family, they are
No, I
bereaved
think
and all
sometime
that.
back there
He
was a
said
circular.
no.
Maybe the circular is not in effect.
No, but then we can't do it, no, unless the circular is there, even the director agreed. So, but
No,
like
but
our
if we say postmortem is necessary, because though the cause is dengue, all dengue patients cannot die, no. So I mean, whenever a death occurred in our hospital, we have written that postmortem is necessary. Even in your other cases, the clinician can write. You don't really need the Ministry of Health. You can always write at the when a patient dies. When you have to write the cause of death, you have to write postmortem necessary. Then they will have to do a postmortem. If the clinician or the person who managed says postmortem is necessary, you can. I think you should do that. Okay, thank you.
Thank you. On behalf of Sri Lanka College of Paediatricians, I would like to thank Dr. Lakshma Fernandez for his excellent lecture, and thank you all for being present here and for attending to listening. Thank you.
All right.